I'm Heidi Abraham. I'm the Chief Deputy Medical Director for Austin Travis County EMS, as well as the Medical Director for New Braunfels Fire Department. A couple months ago, we noticed that we were starting to have more micro-premie deliveries in the field and realized that we needed to do some more training on this particular patient population. So I've done this lecture at the Texas EMS conference and a couple other locations, and decided to get together with Dr. Jeff Jarvis and his team up at MedStar in Fort Worth, as well as the fabulous folks here at Williamson County and my agencies to put together this training for all of our providers on how to deal with this super challenging population. So today we're going to talk about everybody's favorite topic, not just pediatrics, but pediatric patients who are so small and so young they shouldn't even be here yet. We're going to talk about micro-premie resuscitation. Now, where this talk came from, we found that we had a number of micro-premies born in the field and figured we should probably do a little bit more training and preparation for these patients, since most agencies don't have a lot of training. They don't carry a lot of the equipment necessary for these super tiny humans. We know that historically, these micro-premies don't tend to do well regardless of where they're born. They have even worse outcomes when they're born in the field. And we're going to do what we can to help improve those survival numbers for these patients. Disclaimer, I am not a pediatrician. I have worked in pediatric emergency departments most of my career since finishing residency. I love this patient population, and I get to do a lot with them out in the field and education for our agency, but I'm not a pediatrician. So go talk with your local pediatricians. Use your children's hospital. They're a fantastic resource, obviously, for these types of patients. Most of your pediatric hospitals probably actually have a micro-premie mannequin that is frighteningly realistic and will give you some awesome simulation training. So go talk with your children's hospitals for that educational experience. Okay, a couple things mindset-wise that I want you to keep in mind as we talk about this particular topic. First of all, these are still humans, okay? We're not talking about how to resuscitate giraffes. Those airways are a nightmare. We're not talking about how to resuscitate baby elephants or penguins, although they're pretty cute. We're still talking about humans, okay? And despite some changes to their anatomy and physiology that we'll talk about later, they're still humans. They still have a brain and a heart and 2 lungs and blood vessels and a trachea and, you know, all the rest of that kind of stuff. They still need the same kinds of things that bigger size humans need. They still need oxygenation and ventilation and circulation and sugar and all the rest of that kind of wonderful stuff. So we're still talking about humans, just on a much smaller scale than we're used to. Here's the other fun thought from a mindset standpoint. You guys, as EMS, are the experts at resuscitation. You see more sick, unstable patients than anybody else in the world of healthcare. The emergency department, yes, we have a handful of super sick patients who get dropped off at our doorway, but most of our super sick patients come in through EMS, and anywhere that has a good EMS system, those patients are already fairly stabilized before they get to the emergency department. There's not much left for me to do in the ER other than check some blood work, get some imaging, continue some more advanced treatment, but EMS has already started the stabilization process. And certainly by the time these patients get to the intensive care unit, I've already done everything that's left to do in the ER, right? I've already managed their airway, they've got a central line, I've probably diagnosed what's going on with them, or at least ruled out a bunch of the other big bad stuff. And it's now up to the ICU to manage more of an ongoing kind of resuscitation. The initial resuscitation of the undifferentiated crashing patient is your specialty in EMS. This is your area of expertise, no matter the size or the age of the patient. Congratulations, you're the expert. What else? This topic still needs more deliberate thought and practice and study than what you're going to get in this hour. This hour is hopefully going to give you a bunch of the tools necessary to get started in the right direction. It's going to give you a boost of confidence. It's going to make you more prepared for the next time you see one of these patients out in the field. You still need to do more training on your own. You still need to go read articles, listen to podcasts, like I said, talk with your children's hospital, do some simulation-based training. This lecture is not enough to arm you to run a super awesome resuscitation without any further training, but it's hopefully going to be a big step in the right direction. The next thing I want you to think about is why you're doing what you're doing, okay? With each step of this resuscitation, if you just think about it as an algorithm of A, B, C, or whatever useful mnemonic you want to use, it's going to turn into very much trying to remember a recipe under stress. But if you think about what your goals are with the resuscitation, kids are all about respiration. They're all about ventilation and oxygenation. If you remember that that's your goal, it makes it a lot easier to remember what I need to do to get there. The other thing I want you to reframe this conversation as, a lot of people view these kind of as a threat, right? We are terrified of getting that call for a pediatric patient. We're especially terrified of getting that call for a preemie born in the field, or even a micro-premie born in the field. Rather than viewing it as a threat, I want you to think about it as a challenge. And that mindset shift is going to be huge for helping you to embrace these concepts, get more comfortable with them, and maybe not necessarily look forward to these calls, but feel a lot more comfortable with these calls when they come. Couple of thoughts before these calls come. You need to be good at what you do at a baseline. How you handle a normal pediatric call is how you're going to handle these micro-premies as well. You can't expect to be good at micro-premie resuscitation if you're not good at baseline at running normal pediatric calls in your system. If you're not there, that's probably a good place to start. You want to establish a relationship ahead of time with your children's hospitals. The first time to get to talking with the EMS coordinators and the charge nurses and the NICU team at your children's hospital is probably not when you're rolling in hot with one of these patients. Go talk to them ahead of time, do training with them ahead of time, establish a relationship beforehand. It's going to make these patients a lot more of a smoother process. And then you have to have some kind of reference. I have no financial interest. I've used all these different resources that I've mentioned on the screen. There's probably some others out there, but have some kind of resource that's helping you calculate these doses. One of the things that I have found resuscitating these patients out in the field, some of the things like calculating the size of epidose that I need to give these kids, or the size of equipment that I need to use to manage their airway, that is not something that your brain can handle well under stress. So you need to have a reference that you can look that up in without having to sit there and do math in the moment. Another change that we found really helpful in our systems was to send double the resources to these call types. Sick children are not frequent in most systems, which is nice, but that means that most people don't have a lot of experience with these patients, and they're still stressful situations. So giving double the number of medic units, double the number of supervisors, and if you're lucky enough to have physicians or PAs out in the field, this is a fantastic call to try and make sure that they get sent on also. Having extra hands just to do all the things that need to get done and extra brains to help think through all the stuff that needs to be done has been a huge help on these calls. I've been fortunate enough to be on a number of pediatric resuscitations of various types now where we've had double those resources, and it has been such a difference to have an overwhelming number of people, not an overwhelming number of people, but like a plethora of crews available. So I can say, hey, I need you two to just go focus on the airway, get it stabilized, get it figured out. Check that off, right? I need you guys to go figure out vascular access. I need you to figure out my dosing. And having enough people to really divvy out the tasks lets those tasks be done really well and makes the overall resuscitation run much more smoothly. So I would encourage, if you have the resources for it, send double the resources on these pediatric calls. Okay. Call for more help. We talked about that. Get on the phone with your medical director en route to the call if you need to, just to kind of run through, hey, here's my plan, here's what we're going to do. Turn on the heat in the back of the ambulance. I want you to think of these patients almost as a trauma patient, especially these micro-premies have zero extra body fat. They're going to get cold very, very quickly. On the micro-premie resuscitation that I've run out in the field, it was almost surprising how much brain power I spent on making sure that that kid stayed warm. So turn on the heat in the back of the ambulance, be prepared to really keep these kids super warm. Notify the receiving hospital as soon as you can ahead of time. There's a lot of resources that they need to mobilize on the hospital side, and as much advance warning as you can give them, the better the preparation is going to be once you get there. They need to get their NICU ready, they need to get their equipment ready, they need to have the physician team ready, nurses, respiratory therapy, all that kind of stuff. So even if it's a quick phone call shortly after you get on scene, hey, we've got a 22-weeker, we're going to be doing some resuscitation here, we'll let you know when we're en route. It gives the hospital time to get ready as well. Get your OB kit opened up, save the bag. You may need that plastic to help keep the kiddo warm. We'll talk about that in a little bit. Prepare your heating pads. There's a number of different larger heating mattresses that you can use. In a pinch, which is what we had to do on one of our calls, we just took a bunch of the little hand warmer kind of things that you can, shake up, and we used a number of those to create kind of a warming pad. But you're going to want something to help create external heat for this kiddo. Get your BVM and your mask out. We're going to talk about the need for a smaller mask because most of your neonatal masks are going to cover the entire face on these micro-preemies. So you're going to need some smaller stuff there. We'll talk about airway equipment, getting your monitor correct, getting out a good pulse ox, how we're going to monitor cardiac activity. We'll talk about all that kind of stuff, and then get your app opened up and pull up whatever the smallest size is. We'll talk about what kind of weight to go with in a pinch. Okay, so who's at risk for having a preemie delivery, and especially a micro-preemie delivery? And we'll talk about the definition of micro-preemie in a little bit. Moms with multiple gestations, so twins, triplets, quadruplets, going up from there. The more babies there are packed in there, the more likely they are to pop out early. Incompetent cervix. There's a number of different types of infections that can make mom at risk for a premature delivery. Placenta previa is a big one, premature rupture of the membranes. There's a lot of different drugs that can do this, and they do it by causing basically an incompetent placenta. So cocaine, nicotine, drugs that are going to affect the blood vessels and kind of make them smaller and not as efficient are just going to make the placenta weaker and baby's going to pop out earlier. Preeclampsia, eclampsia, general poor prenatal care. But the thing to remember is those are all some of the big risk factors that we tend to see. This can happen to totally normal, healthy moms with good prenatal care and no other risk factors. So it can happen to anybody. So what age is the current age of viability? Well, this was a little bit interesting when I was looking back through the literature. There's a couple different numbers, and it seems to depend on how aggressively that country tends to resuscitate these preemies. There were some interesting studies published out of Japan showing, hey, if you actually try, kids are living as young as 22 weeks with decent outcomes. Also, girl patients are more likely to survive than boy patients. Not sure why. There's a lot of variability out there. There's a lot of different numbers. Certainly that age of viability is getting pushed younger and younger as we go. Generally speaking, patients who are born out of hospital don't tend to have as good outcomes as patients who are born in the hospital for all the reasons, right? Probably born to moms with poorer prenatal care, may not get resuscitated as quickly just because you have to wait for whatever public safety, fire, EMS, whoever to get there. So not as awesome outcomes in the pre-hospital field. Like I said, we're hoping to help improve that with this lecture today. So what exactly is a micro-preemie? Well, it is a preemie who is small. But there's actual definitions for it. So birth weight less than 500 grams. None of you are running around with a scale on your ambulance. So that's a guesstimate. By the way, 500 grams is about the number that we're going to use for our dosing weight for epinephrine and glucose and those kinds of things. Or a baby who's less than 24 weeks. The challenge with these patients in the pre-hospital environment is you may not know how old the baby is. The last micro-preemie that I was part of a resuscitation for in the pre-hospital environment, mom truly did not know that she was pregnant. We had no idea how old the kid was. So we were going off of physical exam findings to try and sort out how old do we think this child is, how likely are the chances of a successful resuscitation. A couple things to help guide that as far as physical exam. If the fundus is lower than the umbilicus, that's probably less than 20 weeks. So if you managed to get there before baby popped out and could feel where the top of the uterus is, if it's above mom's belly button, you're over 20 weeks. Can't tell you any more specifically than that, but over 20 weeks. In the field, that has generally been the guideline that we use as viable, not viable, especially if we're talking about things like a perimortem C-section or something like that. If mom is unsure how far along she is and she thinks she's somewhere around 20 weeks, great, let's go with 20 weeks. Finger webbing. This is usually gone by about 12 weeks. So those hands start with the fingers fused. The fusing is usually gone by about 12 weeks, but it can last up until the 25 week phase. So that's helpful, but not super definitive. Eyes will remain fused until 26 weeks. And we said we're kind of going with 22 weeks as our age of youngest viability. So eyes being fused doesn't tell me a whole lot about whether or not this kiddo is viable. The skin is still going to be gelatinous up until the mid 20 week kind of phase. Baby's head is going to be about the size of a tennis ball. If the skin is so translucent that you are able to see organs and individual muscles through the skin, that is probably too young to be viable. Other than that, it's a whole bunch of taking the physical exam in general into account, taking whatever history you can get from mom into account, and just looking at what is the kiddo doing. If the kid is completely pulseless and apneic and has a lot of these other physical exam findings, kid is probably too young to be viable. If the kid has any kind of a pulse, is making any kind of respiratory effort, I would say generally speaking, I would err on the side of attempting resuscitation on that child. All right, so let's talk about some specific anatomy and physiology differences with these kiddos. They are still developing. Their 22 weeks is barely the halfway point for these pregnancies. And there's a lot of development that this kid still has to do. They just came out of the oven a little too early. So let's talk about what's missing. This is a slide talking about the lung development in these kiddos. And if you notice, the alveolar type 2 cell doesn't start to show up until about 36 weeks. Okay, the alveolar type 2 cell is important because that's the one that allows oxygen exchange across the membrane. Up until that cell develops, starts to develop around the 24 to 36 week phase, is really starting to develop post 36 weeks. So when I have a kiddo at 22 weeks, they really don't have much of those. That means they have much thicker cells forming the alveoli area that's going to develop in the lungs. Oxygen has a really hard time diffusing across those cells. There's also no surfactant yet. Surfactant comes much later in pregnancy. And surfactant, remember, is the fluid that allows the oxygen to diffuse easily across that single cell layer. So kiddo doesn't have thin enough cells, kiddo doesn't have surfactant to help facilitate that exchange. Oxygenation is huge in pediatrics. Oxygenation, oxygenation, oxygenation. If you remember nothing else from this lecture, remember that kids need oxygenation. So it's already a challenge for kids. It is triple as hard in these premature babies because they don't have any of the necessary stuff in the lungs yet to help facilitate that. So you're going to find bagging the kid, you're going to need to use a little bit more pressure just because their lungs are super stiff, probably slightly higher tidal volumes than you might calculate. You're going to have to work a little bit harder at getting good oxygenation. Let's talk about cardiac stuff. So even in a kid whose heart is developing appropriately and normally, we're not talking any congenital heart disease, transposition of great vessels, extra holes where there shouldn't be, even in a kid who is normally developing, you're still going to have some different holes and connections there that shouldn't be there long term. And those holes and connections are going to be a little bit bigger the more premature the baby is, okay? Doesn't have a ton of major implications for us in the pre-hospital environment. It just kind of goes along with circulation is going to be a little bit interesting. Getting them well oxygenated is going to be a little bit challenging. It is very common to have those holes. If you try and listen to the kid's heart, you're going to hear some big murmurs. That's normal, okay? As a general rule of thumb, get used to listening to pediatric hearts. Kids have murmurs at baseline. It is normal for kids to have murmurs. But there are good murmurs and there are bad murmurs. And the only way that you're going to identify bad murmurs in the pre-hospital environment is by being good at recognizing good murmurs. So get in the habit of listening to every kid's heart, no matter what's wrong with them, just so you can get used to, oh, this is what normal murmurs sound like. So that when you hear bad murmurs, you can kind of identify, oh, I'm worried about congenital heart disease. Skin. So skin in these kiddos is super, super fragile. Normal skin has about 10 different layers of different skin types, different cell types. Those are not all fully developed yet in a preemie, and especially in a micro-premie. Skin is important because it helps maintain warmth and it prevents from infection. Does a bunch of other things too, but those are the two that we especially care about in these kiddos. Because the skin is not well developed yet, they're very poor at maintaining their own body heat, and they are very prone to infection. This is especially a challenge for us in the pre-hospital environment because it's a dirty environment that we're working in. So you need to be especially thoughtful about keeping the environment as clean as possible, making sure that your vascular access is as clean and sterile-ish as you can get it, just being very thoughtful about the amount of dirt and germs that you're exposing this kid to because they have nothing to fight against it with. Speaking of which, these alien-looking items are your antibodies. Antibodies cross the placenta and get to the baby during the 3rd trimester. Kiddo who pops out in the mid 20-week range hasn't gotten there yet. So a kid at this point has no antibodies. So their skin isn't protecting them from infections and they don't have any antibodies to protect them from infections. They are super prone to infection. Be very thoughtful about that in the pre-hospital environment. Okay, their brain is the other place that these kiddos get into trouble. Brain bleeds in preemies and micro-preemies is unfortunately super common. And that's one of the things that has really big long-term implications for these kids. Those brain bleeds can cause everything from like total strokes for these kids to hydrocephalus, long-term issues dealing with that, developmental issues, all those kinds of things. The problem for their brains is their blood vessels are so tiny and so fragile that they can rupture very easily and cause a brain bleed without a whole lot of stress. When you're pushing medications, you've got to push those medications slowly. If you slam those fluids, slam the flush, slam the meds, anything like that, you're literally going to explode the blood vessels in their brain. We also encourage being very gentle and very thoughtful about how you're moving these kiddos. So any rapid movement, because everything is so fragile in their brains, any rapid movement can tear those blood vessels and cause a brain bleed as well. When you're driving to the hospital, be careful of the potholes, depending on what city you're driving in, right?
Oh no, I'm a pothole.
So just be thoughtful about the roads that you're driving over and how you're moving the kid and all that kind of stuff, because there's so much at risk for tearing those blood vessels. The other thing to be thoughtful of is the vasculature running through the neck. Kids at baseline are a giant bowling ball on a tiny little stick figure body, okay? And especially in the micro-premie world, their head is huge, their body is tiny, and it's very easy to kink off the blood vessels, both artery and vein running through the neck. So be very thoughtful about putting padding behind the shoulders, opening the airway carefully, making sure that you're keeping those blood vessels as straight and unoccluded as you possibly can. Okay, so we've talked about the anatomy and physiology. We've defined the population that we're dealing with. You've been dispatched. Mom didn't know she was pregnant. Baby's popped out. We think the kid is maybe somewhere around the 23-week time period. What do? I'm on scene. Okay, first problem that you're going to run into. When do I cut the cord? So you show up, baby's still attached to mom, cord is still attached, and what do? Do I cut the cord immediately and take the baby to another room and start resuscitation? Do I start resuscitation right there on mom's lap? Do I leave the cord attached? There's not a ton of literature on micro-preemies in general, just because it's not a large population, period. But the literature that's out there suggests that the longer you can leave the cord attached, the better the outcome is going to be for the kiddo, which makes sense, right? So the longer that cord is attached, the more blood is getting from mom to baby.
You get about 1 liter of blood back into your baby if you allow that blood to keep pulsating and moving through the umbilical cord.
And what's in that blood? Well, there's oxygen carrying capacity coming in the red blood cells, but there's also platelets and clotting factors. So as much additional clotting ability as I can get to the baby, the less likely they are to have brain bleeds or significant brain bleeds, and the better their outcome. So the recommendation is, if you can leave that cord attached for at least 5 minutes, that's probably a good, any extra benefit, any extra blood that you can get to them, the better. Decreases the risk of intraventricular hemorrhage, decreases the risk of necrotizing enterocolitis, which is necrosis to the guts, another big thing that these preemies deal with. And it just helps with the overall cardiac system. Remember, we said there's a lot of different holes there and things aren't pumping quite as normally as we would like them to. The more additional blood volume we can give, the better the heart is going to be able to manage things. So start your resuscitation on mom's lap. Start stabilizing mom, get her wrapped up, get her warmed up, dried off, whatever it is. Start compressions right there on mom's lap if you need to, but leave the cord attached if possible while you start your resuscitation. If you can't leave the cord attached, if you have to cut it and resuscitate mom, resuscitate baby for some reason, that's fine. But if you can leave it attached, it's probably a good idea. Priorities. Positive pressure ventilation is going to be huge. Circulatory stabilization we'll talk about, and keeping the kid warm. And then we'll talk about when exactly we want to transport. These are probably kiddos that I want to start transporting sooner rather than later. Hopefully most agencies at this point understand the concept or are on board with the concept of stabilizing first and then getting en route to the hospital. This is one where, let's get some basic stabilization going, but there's a lot more resources at the hospital that this kid needs than what we're able to provide pre-hospital. More advanced airway support is one of the big things that we can't provide as much of, and surfactant for those lungs is another thing that is just not practical or feasible or economic for us to carry in the pre-hospital environment. They have that at the hospital. That's going to be huge for helping the kids' oxygenation and ventilation. Really big reason to get going to the hospital sooner rather than later. There is some basic resuscitation that we need to do on scene first. Okay, you've got to keep this kid warm. Like I said earlier, I was not prepared for the amount of times during this micro-premie resuscitation that we had a couple months ago to be saying, let's keep the kid warm, let's keep the kid warm, let's keep the kid warm, right? We found that every time we would uncover this child to work on vascular access, to get the pads applied, to get the oxygen, the pulse ox probe applied, all that kind of stuff, these kids get cold so quickly. So you really need to focus on keeping the kid warm. In the hospital, they're basically creating a greenhouse environment for this child. They literally wrap the micro-preemies in plastic wrap. You can look up pictures on the internet. The airway stays out, okay, for all of you wondering, head stays out, rest of the body gets wrapped in plastic, and then they get put in the warmer with the heat on, and it's a greenhouse. It is a warm, humid greenhouse environment for these little kiddos to keep growing in. Pre-hospital, couple different options. You can wrap them in plastic wrap, okay, again, with the airway staying out. You can put them in a plastic bag. Our neonatal kit comes, or ROB kit comes with like this large plastic sheet that you can wrap over the baby in a pinch. That the plastic bag that your OB kit comes in, rip that open, you can put the baby inside of there. Any kind of plastic. Anybody who spent time in a hazmat suit, you know how well that plastic can keep that heat and humidity in. In this case, that's what we want for these kiddos. Like I said, there's a couple different types of like transport warmers that you can shake up and activate and they'll get warm. You want to have a blanket, some kind of cloth between that plastic, that heating component and the kiddo in their skin, just for protection. You're basically going to create like a giant burrito with the kid in the middle, cloth on either side, warmers outside, or plastic cloth warmers to build as much heat as you can for this child. Equipment. What monitoring equipment do I want on this kiddo? I want some kind of monitoring equipment, okay? I'm going to run my resuscitation off of their heart rate. If I had to pick one vital sign, and this applies for pediatrics up through like several years of age, if I had to pick one vital sign to run an entire pediatric resuscitation off of, I don't really care about their oxygenation. I don't really care about their blood pressure. I care about their heart rate. Their heart rate is going to guide everything. Their heart rate tells me when we need to be doing CPR. Heart rate tells me how well our resuscitation is working, tells me when I need to focus on just ventilations. Heart rate is key. So that's two things to remember now, right? Oxygenation is huge, and if I have to pick one vital sign to run a resuscitation off of, it's going to be my heart rate. So I need some way to monitor this kid's heart rate other than just putting my hand or a stethoscope on their chest. Preemies, you might be able to fit like an actual, 3 or 4 stickers on there. Micro-preemies, there's no way you're going to be able to fit enough stickers on there to monitor their heart. You're just going to take your AED pads and put them on front and back. Your AED pads, even the pediatric size, are probably going to be too big for these micro-preemies. You can take, so if you look at that pad, there's like an electrical area in the middle and then there's white sticky stuff around it. You can cut off the white sticky stuff, just don't cut that silver electrical part in the middle. So trim off the sticker part as much as you need to, one pad on the kid's chest, one pad on the kid's back. No, you're probably never going to shock these kiddos. They're almost never in a shockable rhythm, but that's a really great way to be able to see what their heart rate is doing. Now you have it on the monitor, and the entire resuscitation team can keep an eye on how well our resuscitation is going. I do want a pulse ox on there. That's going to be my next step. Put it on their right wrist, okay? I remember we talked about the connections in the heart. There's a ductus arteriosus that comes off, and based on where it comes off, the blood supply to the left side of the body can be a little bit different from the right side of the body. So pulse ox goes on the right side because it's preductal. That's going to give me my most accurate picture of oxygenation. So even on a micro-preemie, their wrist is about the size of my finger. Pulse ox is going to fit just fine. There's all kinds of fancy algorithms. You should reference those. Hopefully your protocols have a guideline for that. The gist of it is I'm doing CPR when their heart rate is less than 60, and I'm bagging them when their heart rate is less than 100, okay? Ventilation is huge. For every 30 seconds that ventilation is delayed, the risk of a prolonged admission for this kiddo or death increases by 16%. So when I tell you that ventilation and oxygenation is huge for these kiddos, like really, really huge, okay? Every 30 seconds, 16% chance of a longer hospital admission or death. So gotta get on that ventilation and oxygenation quickly. Okay, let's talk the logistics. I wanna breathe once a second, okay? 60 breaths a minute, 1 breath a second. I'm thinking about my tidal volume, but I'm using it just as a ballpark, okay? Because I'm probably gonna need to work a little bit harder to get oxygen into these kiddos. So let's talk numbers for just a second. I know we said we don't wanna do math in a stressful situation, but I want you to be thinking about like, what kind of numbers am I actually dealing with? What's the size of stuff? For example, by the way, this kiddo's heart is the size of my thumbnail, okay? When a kiddo is born full term, their heart is the size of a walnut. So when they're born at 22 weeks, we're talking like the size of a hazelnut, okay? I don't know any Texas-sized item that's small enough to compare that to. It's really small. Their heart is tiny, okay? So when you're doing chest compressions, I mean, one little finger is all you need, okay? Talk about lungs. So our general tidal volume is generally 8 to 10, 6 to 10 mLs per kilo, okay? We said we're gonna use 500 grams or half a kilo as our kind of generic weight for these preemie, micro-preemie babies. So if 10 mLs per kilo is my normal tidal volume, I'm talking 5 mLs as a tidal volume for this kiddo, okay? Now, use that as a ballpark because their lungs are a little bit stiffer. You're gonna have to work a little bit harder. You're mostly going until you have chest rise and fall, okay? And you're watching that you're not inflating the stomach. But use that 5 to 10 mLs as kind of the baseline for like, I shouldn't have to go much higher than that in order to get good ventilation. Absolutely want to use positive pressure ventilation. It is not enough to just put an oxygen mask on this kiddo unless they're really breathing adequately and don't look like they're in any respiratory distress. Preemies, micro-preemies, you're gonna need to use positive pressure ventilation. And the reason, remember going back, their alveoli are tiny little bags of flesh at this point. They're not really opened up and they don't have any surfactant to help that oxygen diffuse. So I'm gonna have to use pressure to get the oxygen across as much as possible. Lungs are gonna be a little bit stiffer. Initially, you can start with room air and kind of see how the resuscitation is going, see how the kiddo's heart rate is doing, especially. They have actually found that oxygen is bad in these kiddos unless the child is in cardiac arrest. So heart rate less than 60, yes, you're using oxygen. Anything higher than that, if you're not doing chest compressions, you should be trying to use just room air or at least turning your oxygen down as much as you can while still maintaining good O2 sats and a good heart rate. Back when I first started in EMS, right, it was oxygen for everything. Mona for heart attacks, oxygen for all your trauma patients. And what we found over the years is oxygen is a drug, just like everything else, and we probably shouldn't be using it quite as much as we used to. So now we know that we don't want to put oxygen on our STEMI and stroke patients unless they're actually hypoxic. We've found over the last couple of years we don't want to be using oxygen on our trauma patients unless they actually need it because of the significant vasoconstriction that it can cause. And in this preemie, micro-preemie population, we have found that oxygen, too much oxygen increases the risk of bronchopulmonary dysplasia, which is kind of the long-term pulmonary problems that these kids run into, increases the risk of bacterial sepsis, and actually increases the risk of neurological impairment. So, when possible, keep that oxygen number as low as you can. Just like with every other patient, the HOP killers that we talk about for our adult patients, hypoxia, hypotension, and acidosis, they apply to these tiny little humans just as much as they do to more normal sized humans. So I really don't want to go for an endotracheal tube intubation on these kiddos unless I've kind of stabilized some of that stuff first. And in fact, generally speaking, we probably shouldn't be tubing these kids in the field at all. The current guidelines show that positive pressure ventilation through a BiPAP mask actually has better outcomes in these kiddos, and even really tiny babies, they'll put on BiPAP rather than intubating them in the hospital for a couple months while the kiddo grows. So if you can, avoid intubation, really not something that you should have to be doing much in the field. If you get there, let's talk about airway. We no longer do routine or deep suctioning on these kiddos unless we absolutely have to. We found that causes too much trauma, increases the risk of infection, and can stimulate the vagal nerve and cause some significant bradycardia. If the kid needs their airway cleared, if there is actually stuff in there that is making it difficult for the child to breathe and they are in respiratory distress, yes, suction the airway just like you would for any other patient. But we're not doing it routinely. If the kid doesn't look like they need suctioning or help with that, we're not suctioning. Okay, regardless of the presence of meconium, regardless of the age of the kiddo. And like I said earlier, we're not going to tube them unless we absolutely have to. Number needed to treat of 25, that's a pretty low number, okay? That means I only need to treat 25 patients with CPAP instead of an intubation to prevent one death. That's a pretty good number when it comes to number needed to treat. If you do end up having to manage the airway, a couple with an endotracheal tube, a couple things to keep in mind. Their cords don't look like adult cords, okay? Adult cords, we're used to mostly seeing those nice bright white lines. In kiddos, it's pink, a little pink hole just like the esophagus. So it's critical to be marching down the airway, right? Lips, teeth, tongue, epiglottis, airway. If you just stick your blade in there and fish around, you are not gonna know what you're looking at. You're probably going to need a little bit of laryngeal manipulation. We're not talking cricoid pressure, but we're talking actually moving the larynx around a little bit. Remember, really good positioning before you go in there for a look. So good padding behind the shoulders, getting that ear to sternal notch lined up nicely. You're going to need some smaller equipment. as you're putting together your micro-premie equipment kit, say that 10 times fast, you're going to need some smaller equipment there. And then using an elastic tape cut in an X to help secure that tube. Remember, I mean, we're talking like tiny little sizes here. Once you have that tube, even after you've taped it in place, even after you've got it secured, it's probably still a good idea for somebody to actually physically keep a hand on it attached to the kid's, like the roof of the kid's mouth. There is so little plastic sticking into the airway, and there's so much top-heavy stuff on the outside. You've got all of the tubes sticking out, you've got your, hopefully some kind of end-tidal capnography, you've got your BVM attached. It's super easy for that tube to pop out. So keep a really close eye on that. Okay, like I said a second ago, these hearts are tiny. They're the size of a hazelnut, okay? Which, for those of you who don't know what hazelnuts are, it's the size of your thumbnail, okay? We do not start chest compressions immediately. Kids are all about oxygenation and ventilation. We're going to breathe for them for 30 seconds first and see if that brings their heart rate above that 60 number. Fixing their ventilation may fix the circulatory problem. If it doesn't, that's when we're going to start chest compressions. Remember, you want to compress 1/3 the depth of their chest. And regardless of whether you have one rescuer or two, it's going to be three beats, one breath, 3 beats, 1 breath, whether it's one person managing it or 2 people running it, okay? Drugs. You're going to be giving like a drop of epi, okay? You may be giving a saline bolus, which is going to be like half of your saline flush, okay? And maybe you're going to be giving them some dextrose. We'll get to that. So drugs are kind of the last thing that we get to in a preemie resuscitation. It's going to be airway, 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 oxygenation, oxygenation, oxygenation. And then when we fixed everything else there is to fix, then we're going to be getting to epi and our other drugs. If their heart rate is less than 60, despite a minute of chest compressions, that's when you want to start pushing epi and treating it more like our traditional cardiac arrest. We're going to be checking a heart rate every 2 minutes. We're going to be pushing epi every 4 minutes, roughly. Obviously, go with whatever your specific agency and medical director's protocols say for that. Flushes on these kiddos. A flush in an adult would be a 10 ml push. A flush in these kiddos is 1 ml, 1 cc. And remember, we're going to push it super slowly because we want to not blow up the brains, blow up the blood vessels in their brains. Okay. Hypoglycemia, hopefully not much of an issue that you're going to run into, but if you do, remember that hypoglycemia in kiddos is a different number from hypoglycemia in adults. Babies are born at about 60% of mom's blood sugar. So if mom had a fairly normal controlled blood sugar in the 60 to 100 kind of range, it is normal for a kiddo to have a blood sugar under 40, under 50, okay? So fix everything else first. If kiddo, whether a preemie, micro-premie, or a full-term infant, is still looking not quite right, despite fixing oxygenation and heart rate and everything else, consider that glucose could be an issue. Vascular access. Okay. Most agencies at this point are taking umbilical vein catheterization out of their protocols because it requires some specialized equipment, and we do it so rarely. The micro-premie that we resuscitated in the field and brought into the hospital a couple months ago, we had gotten an umbilical vein cath in the field. When we got to the hospital, they like just sank a 22 gauge in a saphenous vein without even thinking about it. Okay, so just because the kiddo is early doesn't mean that you're not still going to have some good blood vessels. You can probably still find a normal IV somewhere on their leg, maybe on the inside of their arm. You can always look on the scalp, just make sure you're not doing it over the fontanelle because brain biopsies are kind of frowned upon. But you can probably actually still find a normal IV. IOs are going to be a little bit of a challenge in the micro-premie population especially, just because they're so small that even your smallest IO needle is probably going to go right through their bone. If you think the kiddo is large enough that you can actually use that small IO, I would use your hand to insert it. I would not use the drill, just so that you can control exactly when it pops through the cortex. With all of your vascular access, make sure to keep it clean. Remember, these kids have very little defense against infection, so let's not introduce any that we can avoid. Check often for infiltration. Their blood vessels are so tiny and so fragile. Even if you're being very careful, even if you're pushing slowly, being thoughtful with your flushes, all that kind of stuff, it's still very possible to blow a vein. So check regularly for infiltration. Depending on your local protocols, medications can go down the tube, especially epinephrine in cardiac arrest, okay? So something to talk about with your particular agency. Follow your local protocols. Probably not going to shock them. These kids are almost never in a shockable rhythm. Kids in general are rarely in a shockable rhythm. About 10% of the time they have a shockable rhythm. Preemies, micro-preemies especially, they're almost never shockable. It's usually a PEA or asystole arrest. Why do I have a picture of whole blood in a micro-premie resuscitation lecture? Whole blood is awesome. I love whole blood. It is making a huge difference. It is saving lives. And it's good for micro-preemies too sometimes. So depending on what is going on with the micro-premie, if it was a situation where they actually may have lost a relatively significant amount of blood, if it's a situation where mom could have lost a significant amount of blood, you should consider that the kid might need blood also. Now here's the big caveat. Not all blood is, whole blood can often have additional antibodies in it that may be unsafe for the baby. So check with what your local blood bank protocols are as far as whether or not they screen for HSV, CMV, that kind of stuff. We try to avoid certain unscreened blood in our super at-risk immunocompromised population. So in our babies, especially preemies and micro-preemies, and in our elderly, cancer, immunocompromised type patients, we want to be a little bit more thoughtful about what type of blood we're giving them. So if your agency carries whole blood, check and see whether or not it's screened for some of those more common viral antibodies before you consider giving it to these kiddos. But if mom had placental abruption, placental rupture, mom had significant hemorrhage, and baby was born as a result of that, baby may be significantly hypovolemic and loss of blood and may need some blood. So consider that possibility. Okay, this is not just an extraterrestrial character. This is actually how you can diagnose a pneumothorax in a baby without using an x-ray. So you can take a light, make sure that you're not holding it so close that you're burning the child's skin, but you can transilluminate the kid's chest. I'm not going to try and figure out right versus left. The picture that says it's normal is the one that's normal, and the picture that says that it's not normal is the one that's not normal. So when you shine a light on the kid's chest, you don't want that light to go very far. You want it to stop pretty quickly because there is lung tissue in the way. If you shine a light on the kiddo's chest and it goes all the way across to the other side of the chest, that's because there's a collapsed lung. Remember we talked about how fragile their lungs are, how underdeveloped their lungs are, and how you're going to need to use a little bit more positive pressure to get oxygen across the membrane. Sometimes that causes a collapsed lung, okay? And if it turns into a tension physiology, where I've got significant tachycardia that I don't have any other explanation for, congratulations, now you're dealing with a tension pneumothorax in a micro-premie. I'd get on the phone with your medical director at that point. And I would treat it the same way that you treat other tension pneumos. Okay, when would I stop a resuscitation in the field? This is the discussion to have ahead of time as far as whether or not that is even something that your agency is going to do, or if all of these are going to be automatic transports to the hospital. Especially in some more rural or remote areas, you may consider stopping the resuscitation on scene. The guidelines say if the child remains pulseless for 10 minutes or has a heart rate less than 60 for 20 minutes, that is an appropriate time to terminate the resuscitation. Again, this is something to figure out a policy for ahead of time with your agency, figure out what protocols your medical director wants before you get to that point. Okay, here's the other challenge, and here's where it's helpful to have additional crews on scene. You have two patients here. One of your patients may be very stable, mom may be doing just fine, and kiddo may be your sickest, or depending on the situation, the circumstances of the precipitous delivery, you may have two very sick patients on your hands. Mom is probably the one who needs more ALS care initially. Baby resuscitation is actually a whole lot of BLS care, okay? And I know the basics listening to this lecture may not be very excited to hear that, but congratulations, you guys are getting the kiddo, and your ALS partners are going to be taking care of mom initially if mom is the sicker one of the two patients, okay? But don't forget about mom. She needs to be warmed up, dried off, stop the bleeding. She may need TXA, she may need blood, calcium, all the rest of that kind of stuff. Pay attention to both of your patients. Okay, training opportunities. This lecture is giving you hopefully a good foundation to start with. You need to go figure out ways to apply this. Talk with your children's hospital. Like I said, there's a picture of the micro-premie mannequin from our children's hospital, one of our children's hospitals here in Austin. We had some awesome simulation training with that that really gave us a big confidence boost in being able to deal with these patients out in the field. So talk with your children's hospital about that. Let's talk about some long-term complications for these kiddos, both that you should be aware of during the resuscitation and the types of patients that you may run into down the road who used to be preemies and are now, older older patients. A lot of them are going to end up with a trach just because of long-term airway complications. BPD, CLD, bronchopulmonary dysplasia, or chronic lung disease, long-term complications just from underdeveloped lungs being hit with oxygen and artificial surfactant and all the rest of that kind of stuff, they're at risk for long-term pulmonary complications. They tend to be at higher risk for asthma and reactive airway disease. They're more susceptible to RSV and all those other like pulmonary viral illnesses, especially those first couple of years of life. Plagiocephaly, brachiocephaly, malformations of the head, that tends to be a little bit more of a cosmetic issue. You see the kiddos running around with the helmets. That's because of that. Brain bleeds. We talked about the huge risk for brain bleeds, all the long-term complications from that. Cerebral palsy, seizures, hydrocephalus, shunts, all those kinds of complications. Retinopathy of prematurity. If you get oxygen directly in a newborn's eyes, that can cause some complications for the retina, so we try and avoid doing that. Necrotizing enterocolitis, gut issues in general, just again from the infectious risk, the oxygen, the hemodynamic changes, all that kind of stuff. And then developmental delays in general, just from being born so early and from all the stuff that they dealt with in those first couple months of life. So some long-term complications just to be aware of. A couple of different resources to look at. There's an Instagram account that I have enjoyed. It's called NICU Musings. It's a NICU physician just sharing insights on caring for these patients. There's a really cool website to spend some time poking around. It's called Hand to Hold. It was actually started here in Austin, out of St. David's, one of our NICU facilities here in town. Tons of resources on there. It's geared towards families of preemies, but there's a lot of useful information for you as a provider just to be aware of the kinds of things that these families are dealing with, the considerations, what life is going to look like in the NICU, all that kind of stuff. And then there's a couple different research articles that I put up there that you can take a look at as well. So, some take-home points. We talked about a lot of stuff in terms of resuscitation. Some things I want you to remember. Start positive pressure ventilation early. You don't necessarily need 100% FiO2. Room air is just fine for starting. A rising heart rate, we're talking about the baby's heart rate, not yours, is your best indicator of success. If I have to pick one vital sign to run the entire resuscitation off of, it's going to be that heart rate. Remember to check a glucose at some point in your resuscitation, and I want you to view this as a challenge that you're going to go home and study and think about and prepare for, and not as a threat. Thanks for watching.